Please welcome to the stage Kenneth Q, MD, founder, UDoc Direct Primary Care. Emily Scott, MD, co-founder, Halcyon Health Direct Primary Care. Moderated by Aimee Leidich, Head of Operations, Hint Health.
Hello, welcome everyone. We're so glad to have you all here for Hint Summit. For this panel, we will be speaking about trends in direct primary care. I'm Aimee Leidich, and I'll be joined with Kenneth and Emily. I'll go on here to our agenda. So we'll start with introductions, so you get to know the panel. Next, we'll move on to our discussion of DPC trends. So earlier in the year, Hint released the Trends in Direct Primary Care report. We will be going over some high-level, really interesting, amazing findings and database findings about the industry of DPC. And then Kenneth and Emily will be adding in their perspective on the ground from their practices. We really want this to be interactive, so we're going to save a large portion of time at the end for Q&A. So as we go, if you have an anecdote about your own experience, a question to follow up on, remember those, and then we'll have 10 to 15 minutes at the end to hear from the audience. All right, so we'll start with our introductions. I'll go first. My name is Aimee Leidich. I am the head of operations at Hint Health, and I am in charge of the analytics team. So it was our team that put out the report earlier this year. My background is in public health, a lot of biostatistics. I started out in academia. I did a lot of large-scale international research projects through UCSF. I got my feet a little wet in the startup tech world, working on a research platform for a Nairobi-based startup, and I found my way to Hint in 2019. I'm actually from the Denver area originally, so I'm here visiting my parents. And then I now live in San Francisco with my husband and my very cute 2-year-old daughter. Then Emily, why don't you introduce yourself?
So my name is Emily Scott. I'm a family physician and the co-founder and CEO of Halcyon Health. We're based in Irvine, California, and I guess we're representing the past. So we've been open since 2016, so we're in our 6th year now.
Good. Hey everyone, I'm Kenneth Q, and I'm very loud. I'm a family physician. I've been involved with the direct primary care community since I was a med student, and I just finished residency this past summer and opened my practice, UDoc, just outside of Richmond, Virginia.
So we'll get started. So like I mentioned, Hint released the Trends in Direct Primary Care reports earlier this year. On the screen, you should see the QR code. Get out your phones, scan it. You can download the report. We will be going over a handful of some of the really interesting findings, but there's a lot more in the report that you can read through. The report was about many years in the making, took hundreds of hours across the entire Hint team. You see the name tags out there, Emily Murray, Raquel Yates. There are 2 analysts that put a lot of thought and number crunching into this report. We also involved 40 published articles and studies, a lot of data from the 2020 US Census. Hint conducted a consumer survey in the fall, and so we have results from that, from 1,000 consumers on their opinions of DPC. And then the bulk of the report is using our product data. So as people are using Hints, we're able to analyze that and understand different trends. So the data in this report is taking information from any account on Hint that had at least one paying member from January 1st, 2017 to December 31st, 2021. And also, so effectively we're looking at trends from that period, 2017 to 2021. And that will include about 3,500 DPC clinicians and their locations. So it's a lot of information. So let's get started. The theme of the report is growth. So in case you all were wondering, we have data evidence that DPC is growing in a positive upward direction. We looked at the number of active DPC members per 100,000 people. So the population in the US is growing. What we want to see is DPC members to be growing faster than that, which would mean more and more patients are converting to DPC. From 2017 to 2021, we found a 241% growth in DPC members. That's that chart you see, the lighter blue chart. The map that that you see on the screen, that is looking at the same concept, members per population by state. So the darker color are states with a higher density of DPC patients per population. The little hearts are the highest. So Idaho, Utah, and Indiana have the highest density of patients per population. We also looked at growth in membership within a practice. So taking all of this information we have across our platform, we looked at the median % change in membership within a practice. So after 1 year, a practice could expect, had a median % growth of 73% members after 1 year. By the time they had been on our platform for 3 years, so 3 years in operation, that growth had gone up to a 336% growth in members. So kind of starts a little bit slow, but really picks up over time. With this growth in members, we also want to see growth in DPC clinicians. We kind of looking at the same concept, so the number of DPC clinicians per 100,000 people per the population. Again, we want to see these DPC clinicians growing faster than the population, which we did. So that chart that you're looking at, you can see 159% growth in DPC clinicians from 2017 to 2021. And then the map is looking at DPC clinicians per PCPs. Again, this is looking at a density, so those darker colors are places where there are a higher proportion of DPC clinicians per PCPs, meaning in that primary care space, a lot more DPCs are able to serve those patients. The highest density is Colorado, here where we are, Nebraska, and also Idaho. And I'm going to pause here now, and I'll ask my panelists if you have, what can you speak to about growth in your own practices? Emily, why don't we start with you?
Yeah, so I can start with that. So we're in California. As you can see, it's a state that isn't so dark. And we started in 2016. I have been in the community for about 10 years in academics and in ACO, so I had a footprint in the community. And started with about 70 patients. And we have seen this sort of exponential growth that she talked about, where really it's word of mouth. As people come and they have this great experience, they tell other people, and it kind of does this exponential growth. So now we're about 1,200 patients. We have 3 providers, and we're looking for a 4th. So if anybody out there wants to practice DPC in Southern California, let us know. Our region is very heavily HMO predominated. We're in Orange County. So it's really known to be a place where HMOs are really popular. Kaiser's a big presence there. And so when we started, there was a lot of intimidation, a lot of telling us, well, no, you're not going to have a market here in California in this area. And it just wasn't true. So we've had a wait list since September, and we're just really doing great. So, yeah.
So when I was in medical school in Central Virginia, there was one DPC practice. Coming up this summer, there's going to be 6 or 7. Where I did residency, when I started, there were 0 in the eastern part of Virginia. By this summer, there's going to be about 8. So, in a very short time period, there's been just tremendous growth. And I think, I'm just looking at Virginia, but it seems to be happening all over the country as well. And in terms of patients finding out, Virginia is still fairly new to the DPC game, but as people learn, they join on pretty naturally, and they get it. And even though we're growing fast, I imagine we'll probably need to grow faster soon.
On here, the report looks a lot at membership trends, so the price of membership. There's a lot in there. We're looking at it geographically by different types of members, so make sure to read the report. But what here we're just looking at is the price in the median price of DPC membership over time across all of our accounts. And we were thinking along this line of, it's no surprise to anybody here, I would say probably no one in America, that the price of healthcare, insurance premiums, the cost to employers just continues to go up and up and up. And it is growing faster than income. So it's taking up this larger and larger portion of people's money, of companies' money. So this chart that you're looking at here, the light blue line is the % change in median income from the census. So from 2017, incomes have continued to go up. There's a little dip in 2020 around the pandemic, but since 2017, it continues to increase. When we look at DPC membership prices, so if we're taking across our entire database, There's a slight decline, but overall it's a decline of 3%. It was a difference of a few dollars in a membership price, but overall that has just stayed the same. So DPC memberships in comparison are taking up less and less of people's hard-earned money, which is great to see. And do you have thoughts about membership pricing?
Yeah, so we were talking before about when we started our practice in 2016, we were scared. We wanted to make sure it worked, so we made these 4 different price tiers based on age. We thought, what 20-something is going to pay a bunch of money for this thing? And over the years, what we found out is that plenty of 20-somethings will pay for it, and they tend to sometimes be as complex as some of the older patients we have. So what we've done through the years is kind of removed those lower price tiers, and now we just have 1 price tier. So we haven't raised the prices on our existing patients, but new patients that come in are paying us at that higher level. And so in essence, we're sort of building a higher revenue with our practice that way. The other thing that came up for me with the price tiers was this idea that, at some point they're going to age up with the prices, and we'll have these patients who have been loyal, who are, we have this great relationship with, and then all of a sudden they're going to have to pay us, we were raising it $20 more a month. And that always didn't feel right, or certain patients, we just didn't feel like that made sense. So we've many times just frozen them at that price point. So for us, it's felt really great just now to have this 1 price point. So just our individual experience with that.
Very cool. So starting out for my practice, I just kind of looked in the region. I also have pricing tiers based off age. Well, what's interesting about this is I think a lot of you guys probably have seen by now the Journal of American Medical Association put out a 10-year study on the state of health insurance for employers, and the growth of premiums has been 55%, while deductibles have increased 110%. Meanwhile, wages have only grown 11%. And so it's something I presented at our local Chamber of Commerce, and a lot of people were actually talking about those numbers too. So people understand what's going on in healthcare with increasing costs, and DPC really, just looking at this number and how it hasn't really changed over time is a great solution to the madness that's going on.
So a huge theme of this report has been the entrance of employers. So we see on the left, the chart, we're looking at the number of employee sponsors. So you can kind of think of that as a company that is sponsoring DPC members on Hint. So that is, you're seeing a very steep hill happening there. So we're getting more and more employers who are adopting DPC. On Hint right now is about 4,000 different employers, which is great. The colors that you're seeing on these charts, this is the size of the employer, the number of enrolled members that are involved in DPC. So that dark color is less than 10 enrolled members. So you can kind of think of it as a smaller sponsor, a smaller company. So as many of you know, DPC is a great option for small businesses. It's a great way for them to be able to provide healthcare and a great benefit to their employees. So we found that among all of the employee sponsors on our platform, about 2/3 of them, almost 60%, have less than 10 enrolled members. So there's those small businesses. With that said, the other bar is looking at among all sponsored members, what size employer are they coming from? What size of sponsor? We saw the inverse. So about 60% of members are from sponsors with more than 250 members. So it doesn't change that DPC is great for a small business, but if you're able to get that large employer, that really brings in a lot of patients and really can expand the access of DPC. Continuing on about employee-sponsored memberships. So this is the same concept. We're looking specifically at employer-sponsored DPC members per the population. Those darker colors means there's more employee-sponsored members per capita. We see a lot of the dark color in the west and the southwest. The states with that highest proportion are, again, Colorado, where we are now, Minnesota, and then also Indiana again. And also speaking to the growth of employers is the concept of networks. So networks is a great way for, say, one DPC has a large employer. They want to sort of share the love and distribute those patients to other DPCs, or a DPC who's looking to fill their panel can take on some more members. So in 2019, which is when Hint introduced the kind of concept or the ability to do networks via our platform, there were 20 states that had at least one network in their state. that in just 2 years, that doubled. So now we see 40 states that have at least one network in their state. So in a very short amount of time, more practices are participating in those networks. And what have you guys seen related to employers?
Yeah, one of the things I'd want to say about this with our practice, even the small employers that come in, you end up getting people who otherwise wouldn't have known about DPC or weren't seeking it out. And then those people come and they're just blown away by the experience, and they go tell 5 other people. And so even with those small employers, you really get some exponential growth from that word of mouth service. And we've seen in our practice, we've really been sort of sitting back and letting everyone come to us. So we've had a lot of small employers approach us. We have not really gone and hustled to try to get big employers, and so we don't have any, over 250 member groups in our practice.
So when I first got involved in DPC as a medical student, I think the people who were doing employer stuff, they were kind of fringe off in the side rooms. But now it's interesting because you almost can't talk about DPC without also talking about working with employers to some degree. And so for a lot of people like myself just starting out, engaging with employers is a part of the kind of plan. And so at my practice right now, we're mostly growing individuals, but I've begun the conversations with business owners just so they kind of know who we are, what we do, and then just understanding that sales cycle is a little bit longer to plant the seeds now and hopefully reap the benefits in a couple of years.
So as this is a little bit looking ahead, this is sort of a fun thing that we found in our analysis. During our consumer survey, we just asked the general public, have you heard of direct primary care? And 68% had not. So it's probably not totally a surprise to people, but what's more encouraging is the increase in people hearing about DPC and wanting to learn more. So the chart you see is the number of Google searches of the term direct primary care. So let's say like 2014, people were maybe dabbling in it, and it is just continuing to go up. So as more people in the public hear the term direct primary care, they're like, I wonder what that means. Then they Google it. So this, to me, is an indicator that more and more people have heard the term, are thinking about it, and want to know more.
Yeah, and just an interesting point on this is, my practice is the first one in our county in Virginia, and some of my patients found our practice by Googling direct primary care, whether it was through their health share or some other online things. So, I think public awareness really is growing, and it's an awesome thing to see.
And now we'd love to hear from you all. I'll leave this screen on with the QR code. So again, I encourage you to download. We have 2 mic runners, I believe, on each side. So we have Alexa and Tasha, and we'd love to hear from you. So if people have questions or thoughts, if you could just raise your hand and they'll come to you.
Session, thank you. You had data on the number of people that have not heard of it. 68% people have not heard of DPC. Do you have data on how many doctors have not heard of DPC?
How many doctors are?
Yeah.
Haven't heard of DPC.
Have not heard of DPC.
Don't. That's a good question. But yeah, no, our survey was among the general population. Maybe there were some doctors in there, but that's a good question. Something to think about.
Thank you.
Good morning. Great presentation. You talked a lot about the employer market and how this can be particularly attractive to small employers. Another recent innovation has been ICHRA. How do you see ICHRA and the DPC movement either amplifying each other, or what do you see the opportunities there for DPC practices from ICHRA?
Behavioral health?
I don't know.
I think you said behavioral health?
ICHRA, which is the individual contribution HRAs.
Yeah.
Is that like a health sharing plan?
No.
It's a way that an employer can pay money to an employee to buy whatever care they want, as opposed to paying for a particular program through.
Okay, yeah, Kenneth has an idea.
Yeah, I mean, there's some employers I've talked to in Virginia who are playing with ICHRA plans right now. I think that's still pretty new territory for a lot of people. So just seeing how it grows, but it doesn't. I think it could work, right, for people who are choosing to go that way, and it kind of skirts the whole HSA issue. So yeah, I think that's definitely something that if employers are looking into, it would be worth having them talk to their local DPCs to see how they can make that work.
Someone. Hello. Okay. Thank you for sharing. I did have a question, not so much about the trends, but you said that you're having conversations with small businesses. How are you starting those conversations? And then my other part of that question would be, is there a specific type of business you're targeting, or are you just any small business?
And Emily, you can speak to that about.
Yeah, okay. So for our practice, honestly, what's happened is we've had individuals come join and the individual owns a business. And so then they're so happy with what service they've had that they want to sign up all their employees. Or they work for a business and they go speak to their CEO and then they come to us to set up a DPC. So that's really how we've grown with our small businesses.
Yeah, and just starting conversations right now. I mentioned I'm in the chamber, so just getting to know some of the people in there. And then I think I'm lucky to have a couple benefits advisors in my area who are really going after people, and I kind of join in on those conversations. Yeah, just kind of whatever's around right now. We've had a couple of CEOs join just to like see exactly what it is before they sign up their people.
Hi, psychiatrist, so subspecialty, sort of. For you as DPCs, if you could just say, this is how we'd like to have the medical discipline of psychiatry, which I will differentiate a little bit from mental health, which is a different thing perhaps, integrated in your practice, how would you like to have access to us? What would work best in your world? If you could just wave a wand and say, this is how we're going to deploy psychiatric and mental health expertise for the patients, where I'm imagining you're basically doing the frontline work now. Question mark.
Yeah, I'd love to start with that. Thank you for asking that question, because what I find in my community is people are coming in and they're paying for DPC, and then they usually will have to pay for psychiatry, and so how can we find this middle ground? So I think having a psychiatrist that I could consult and having this ongoing relationship of handing off to psychiatry when they're beyond my expertise and then taking them back when they're stabilized, and that back and forth just makes so much sense to me. Because a lot of times psychiatries, from my patient's experience, I'm not a psychiatrist, so please, but they seem to find that once they're stabilized, they're going every 3 months and the doctors are just writing their prescription. And so if things are stable, I can manage, but there are times when I need that support. So does that answer your question?
Yeah, and just kind of from a more like higher level, not really boots on the ground for me, is just seeing the development of direct specialty care. And seeing how primary care is starting to interact differently with the specialists. And one of the things that I'm hopeful for that there will be more of is that there's going to be more doctor-to-doctor virtual consults rather than in-person referrals. I think that saves the system a lot of cost and hassle, helps the patient, and I think helps us too, rather than getting records from all these places, just being able to message someone and then have them message us back, I think is super helpful.
Quick question. We're a small DPC shop, 2 providers in Montana. This question is about networks, the DPC networks. In your map, you didn't have any networks at all in Montana. And I'm just wondering if you guys have really positive experiences with any DPC networks. Do you get a lot of referrals from networks? Is that something that we could potentially start in Montana? Do you think it's worth the time and effort to make that happen as a giant state with people that are very spread out?
I can speak a little to that. I'm not sure if I'm going to answer your question directly. We worked for a short time with PeakMed, which has evolved into many different things, but we had a great experience. They had a very large employer with a footprint in our neighborhood, and they didn't have a DPC provider, so we just got handed a bunch of patients, and it was amazing because it really was what you hope it will be, where you're just getting these patients and you get to own them, and there's not this sort of going back to all the things we tried to leave. I've heard about local communities. I think Julie Gunther was talking about a community that came together and all the DPC docs created one website, and that actually helped the flow for them because it looks like they have all these different networks in the community, when it's just, they're all really individual DPCs, that's kind of helped them all float. So does that answer your question? Yeah.
Yeah, there are, I'm not part of a network right now, but there are different iterations. Kind of to Marielle's podcast, she did one with Natalie Gentili for Pittsburgh. They formed an MSO, and then there are other networks like Peak, like Nextera, and a lot of them are here. So if you just talk to the people who do the networks, I think that'll be really helpful.
And also just a shameless plug, Hint Connect is also a network that Hint is working on. And we've done a lot of different analyses on connections and how those come. So we see out there, Beth and G from Hint also have a lot of insight into both from a data perspective and just a relationship perspective. Other question?
Hi, I'm a OBGYN and looking to start my own specialty care practice and in the very baby stages of development. Do you have any words of wisdom, either from the specialty tract or from just like starting up, of how to proceed?
I always have something to say. So I congratulations. First of all, I think that's fantastic. I don't know. Are you planning on doing OB care? Is that your plan?
No, I'm going to do just GYN.
Perfect. Okay. I think, I guess my advice to you is you are very much needed. I think there's a lot of people who, in my practice, who would be happy to have that connection with a GYN. I think I've had patients who want these bundled OB care packages. They want to pay for a bundle package for all the office visits and are really excited about that opportunity in our community, which is not offered enough, in my opinion. So, yeah.
My general take for anyone who's starting up with, congrats, by the way, that's awesome. Residents, med students, specialists, practicing docs, is to get to know the people around you. As we saw, there's growing number of DPC docs everywhere. So try to reach out. Everybody's super friendly, and you'll get a better feel for kind of the need in your community, and they'll even help you with kind of business structure and how they'd like to relate to you. So I think there's a lot of resources out there you can tap into.
So strangely enough, I am from South Dakota, which I think is maybe the only holdout of DPC practices. So
There's
if anybody
one.
wants to come to
Neighboring
South
states.
Dakota.
Neighboring states.
Yeah, there is one. I wrote a thing for DPC News saying that nobody was in South Dakota, and on Facebook somebody wrote, "No, I'm in South Dakota." So I know there's someone there.
Oh, as the population ages, and I'm from a state where our percentage of people over 65 is growing quite quickly. How do you see the DPC practices aging into that? I think one of you mentioned that your practice was starting to see older and older patients, and you had to figure out the tiers. What happens as they get to Medicare age and beyond?
Yes, so for our practice, basically it's the same price point from 26 to however old you're going to be. So there's no price change when you hit Medicare age. We have had patients in the past who say, oh, well, now I've got Medicare, I've got this great insurance, I'm out. And they leave, and then probably within a couple years they come back. So I think that there's a lot of need there. I think particularly I have so much fondness for working with my senior patients. I think we offer so much to them with the availability that we have that they're not getting with their Medicare dollars that they're using.
Yeah, the Medicare issue is a really interesting one for people who are just starting out like myself, especially if you're starting straight out of residency because you're looking to get more people and you might have to have a side hustle. So as you all may or may not know, you cannot direct contract with someone who has Medicare unless you're opted out. And that opt-out time is 2 years. And so if you opt out, you basically can do no moonlighting on the side. So that's a big issue. I think there are ways that people are working around it. We're having the coalition has been working with Medicare on a couple of these issues, but it is a really big challenge right now for people who are starting out like myself.
Great, thank you. And that is time. So thank you everyone for joining us. Come find us if you have questions on the veterans' perspective, the future of DPC, and we love talking about data. So thank you.
Thank you.